Hello, my name is Ruben Mesa, and I'm one of the hematologists at the Mayo Clinic in Scottsdale, Arizona. And in today's program, we're going to be focusing around frontline therapy of patients with p-vera, in particular in those that have had vascular events. As we look at management of patients with polycythemia vera, we begin that all individuals likely benefit from the utilization of low-dose aspirin. And we'll get around to showing you this data in just a moment. Secondly, we try to optimize the prophylaxis against vascular events by controlling the hematocrit, with a goal hematocrit of less than 45% in all individuals. From there, we move to a more selective approach regarding the use of cytoreductive therapy in frontline. So the individual that has had a vascular event, by definition, is an individual who we think has higher risk polycythemia vera, and we need to consider cytoreduction, and depending upon the nature of that vascular event, may in addition need anticoagulation. A patient with a venous thrombotic event, we in particular look at anticoagulation with warfarin or similar products. Individuals with arterial thrombotic events, more on the anti-platelet therapy arena. Finally, individuals, if they are intolerant or resistant to frontline cytoreductive therapy, we need to consider second-line cytoreductive therapy. Now, aspirin in polycythemia vera. This seems inherently logical in the era where we use aspirin as prophylaxis against cardiovascular disease, cerebrovascular disease, atrial fibrillation, amongst other utilization. However, in p-vera in the past, in the 1960s, the p-vera study group performed a study looking at high doses of aspirin compared to placebo and found that the risk of GI bleeding outweighed its benefits. Our colleagues in Europe performed a very appropriate study looking at lower doses of aspirin, specifically the European formulation of baby aspirin at 100 milligrams versus placebo. And with that, they were able to demonstrate a significant reduction in vascular events by the utilization of low-dose aspirin. And this has become a standard approach for patients with p-vera. Now, what about control of the hematocrit? Our colleagues in Italy performed a very elegant study trying to delineate whether the hematocrit target of 45% was too strict, with the negative of having patients below 45 being iron deficiency and exacerbation of disease-related symptoms. So they looked at a low hematocrit group and a high hematocrit group, below 45 or 45 to 50. What they identified was that the difference in hematocrit, although modest, had very significant impact regarding prevention of vascular events, with individuals with the higher hematocrit having overall a fourfold higher risk of vascular events than lower hematocrit targets. So I have taken away from this, for my practice, that individuals, we really need to look at a hematocrit of 45% truly as the ceiling for their hematocrit control. And that if every time I'm checking their hematocrit it's over 45%, I'm probably not checking frequently enough, or I need to be considering cytoreductive therapy. Hydroxyurea has become a de facto frontline therapy for reduction of vascular events in these individuals. It is an older agent, and it is approved, as you see, largely for indications we're not primarily using it for at the moment: refractory CML, ovarian cancer, head and neck cancer, etc. In p-vera, it certainly has been utilized, although with fairly limited data. The data we have is primarily from a p-vera study group trial long ago with hydroxyurea versus phlebotomy, and with this it was superior for reduction of vascular events. However, there has been some concern as to the long-term safety of use of hydroxyurea in patients with p-vera, although the data are controversial, as it's not clear whether a single-agent hydroxyurea increases the risk of acute leukemia, or is it solely in individuals who have used many different additional cytoreductive agents in combination. As take-home points for initial management of patients with p-vera, all p-vera patients require control of hematocrit and antiplatelet therapy. 2, frontline cytoreduction is hydroxyurea for p-vera, although the data we have is fairly modest and there is no formal indication. 3, managing vascular events involves cytoreduction and indefinite anticoagulation in those with thrombosis unless the risk of recurrence is low. Thank you for participating in today's program.